I'm Christina Fournier. I'm a neuromuscular neurologist at Emory University here in Atlanta. And this is my second conference. I'm very excited to be here. My talk actually is a nice follow-up to the previous two talks we've heard today. So we're going to talk about some research challenges in PLS and HSP and how we're making some progress to move that forward. So the reason I decided to do this talk is I know I've had a lot of patients come in my office and they ask, oh, what kind of, is there research happening in HSP and PLS? And we'll talk about it. They say, so where are the trials? And when there's not a lot of trials, I think it's very disappointing. And it can feel like that there's not progress being made in getting treatments for these diseases. But I think you can sense the excitement of the previous speakers. And I'm excited as well that I really do think we are making progress to kind of move the field forward and overcoming some of these challenges. So we're going to kind of highlight what the challenges are and how we overcome them. And some of these have been talked about already, but this is kind of the bird's eye view of what these challenges are. So as kind of an overview, so obviously the end goal here is a cure, but usually treatments are more stepwise in terms of it's very rare to go from no treatments to cure instantly. A lot of times it's kind of stepwise progress in treatments that slow progression or that help manage symptoms. And if we had a cure tomorrow, that would be pretty easy to recognize if someone went from having HSP or PLS to normal. But when you're actually trying to identify a treatment that slows progression, this can be more of a challenge. You actually have to be able to measure progress. And especially in diseases where in HSP and PLS, there's two things in particular that make this more of a challenge. One is these diseases progress pretty slowly over time. So a lot of times you clinically notice changes over years, not so much over weeks and months. And it's very challenging to do a trial that lasts 10 years. And then if everyone with a certain disease looks exactly the same, then you can easily enroll small numbers of patients into a trial. And if one group looks better than the other, then you see the treatment effect. But as you could probably see just from being here, people with HSP or PLS look very different from each other and progress very differently. So the more variability there is within a disease, the larger a trial you have to do to actually detect what's the difference from your drug and what's the difference just from person-to-person variability. So as I said, the fact that it's slowly progressing and it's variable makes it more of a challenge to detect a treatment effect when it's there. And then we've talked about PLS and HSP are both very rare diseases. So you can't just have one center, one city, and do a trial. This is why these networks are so important, where you really have to do multi-center trials all over the country, where you can get enough patients with the disease you're looking for, and you collaborate your information and do trials at many centers. So those are really the big challenges, and we're going to kind of talk more about them and then how we move forward. So we've talked about this. So you really need, you don't want to just give a drug and then say, hey, how do you feel? That doesn't really prove if something is working or not. So you need reproducible measures, meaning that if I were to give the scale to somebody and Sabrina were to give the scale to somebody, that we would get the same result. Because like I said, we're doing these studies at different sites with different investigators. So the way I measure disease has to be the same as the way she measures disease. And then a responsive scale is one that actually detects a change if a change has occurred. So you need sensitive measures that are going to detect subtle changes that might not be obvious just by looking at somebody. And then we've talked a little bit about biomarkers. So in a disease that progresses very slowly, and to the eye, it might not be obvious what changes happen month to month. If you have something you can measure in the blood, on an MRI, in the spinal fluid, that shows changes that are subtle that might be obvious before a clinical change occurs, then that can be helpful as well. Also, if you give a drug and it doesn't work, there's two options. There's one that it didn't even hit the target it was supposed to hit, and one is that you hit that target, but that mechanism doesn't work. And the biomarker lets you sort out one versus the other, and that's important because if you hit your target and it didn't work, then targeting that pathway might not be the way to go to treat a disease. If the drug didn't work because it never hit the target, then you just might need a different drug that actually hits that pathway you're trying to hit. So biomarkers tell you one versus the other, and that's important for moving treatments forward. And in terms of having clinical measures and biomarkers, you need both. So what you want is, yes, you want the biomarker that shows that you hit the target, but you also don't really care about that biomarker if there's no clinically meaningful change. So it's not that one's in competition with the other, it's that one complements the other, and when you have a drug that shows that there's clinical changes and you hit the target and that biomarker moved the way you wanted it to move, then those things together really show you that you have the right drug and can take it forward. So we've kind of touched on these things, but how do we measure a response to treatment in a clinical trial, and why does it actually matter? And answering this question will show you why these observational trials actually are so important in getting ready for drug development. So to give you an example in ALS and why the way you measure things are important. So the previous speakers talked about the scale, the ALS functional rating scale, which asks questions about speech, swallowing, walking, breathing. And in ALS patients, this scale progresses by on average 1 point per month, but it is pretty variable patient to patient. So this new drug that has just been FDA approved to slow progression in ALS is called edaravone. And the way that they got the drug approved was they took 137 patients with ALS, and they actually picked patients that were more similar in the way they progressed, so they wouldn't need as many patients to show their effect. Half the patients got drug, half got placebo, and they followed patients over a 6-month period. And they showed that the patients who got drug progressed a little bit slower than the patients who got the placebo. And so what you're seeing in this graph here is time in months is on the x-axis here, and the score on the ALS functional rating scale, with 48 being normal, 0 being the most severe disease. And both groups progress over time, but this group that got the drug progressed slower than the group that got the placebo. So you could see how without a reliable measure, you could miss this treatment effect. It's not like the patients who got the drug got dramatically better or that they were cured, but they progressed slower. And because there was this measure of disease, then they were able to detect that treatment effect. So this is kind of summary. So in this particular group, the drug group progressed by about 5 points on the scale over 6 months, and the placebo group progressed by an average of 7.5 points over 6 months. And this ALS functional rating scale, so we've talked about how this is also used often in PLS patients, and there's reasons why that's good and reasons why it's sort of doesn't quite work for clinical trials. So I would say that things that are measured in this scale are things that are clinically relevant and we care about. Being able to speak, swallow, write, feed yourself, roll over in bed, walking, climbing stairs, breathing. All of these things that are certainly clinically relevant and things that we want to impact in our treatment. So for that reason, using the scale in PLS can make sense. But where we get into problems is that on average, the ALS FRS only declines by about 0.2 points per month, whereas in ALS it's a point per month. So if you think about that, it's on average about 5 months before you just lose 1 point on the scale. So if you're using this scale as your outcome measure in a PLS trial, then you're probably going to need a trial that's years long and that has hundreds and hundreds of patients, and that's obviously a challenge. Right now, there's not any PLS-specific scales or PLS outcome measures, but with the trials that the previous speakers were talking about, the idea is to create these things so that when candidate drugs come up, that there's ready to go with specific scales and outcome measures to measure these things. So I know it's kind of hard to get people excited for trials that, for research studies that don't offer a treatment, but developing these metrics is so important because you have to have them in order to identify a good drug if it's there. And just another example of why using this ALS FRS scale for PLS is a bit of a challenge. These are just a couple patients from our database that were not in any clinical trial, just that they were tracked over time. You'll see that unlike in the ALS graph we showed you, this is each of these marks is 12 months, so this is over years and years. And again, the ALS FRS scale with 48 being normal, 0 being the most disabled on the y-axis. And what you see in PLS is that it's pretty common for patients to kind of bounce up and down on the scale with regular variability. And that could be either getting symptomatic treatments, things like baclofen or tizanidine that might help. It might be doing physical therapy. It might just be some kind of noise within the scale where there's a little bit of variability time to time. But you could see that if this is what people are doing without treatment over a 5 or 6 year period, if you're trying to measure the effect of a drug that modestly slows progression using the scale, that would be quite challenging because, again, it would be really tough to do a 10-year clinical trial, and over a 1-year period, there's patients that are going to be going up and down on this scale just as the natural course of their disease. So this is really why the PLS scales and biomarkers are so important. Moving to HSP, so this scale was also explained, the Spastic Paraplegia Rating Scale, where the ALS functional rating scale is the patient reports how they're doing. This is measured by the neurologist. It takes about 15 minutes to do. Again, it's reversed where 0 is the best score, 52 would be the most disabled. And this scale, like I said, it's good. It's measuring clinically relevant things. We care about the outcomes that are being captured in here. But this scale declines by an average of 0.08 points per month. So it takes about a year to decline by 1 point for the average HSP patient. So again, using this as the primary outcome in a trial we were trying to detect modest treatment effects would be really tough. You'd have to follow patients for years and years and years. I think the slide was shown before, but just to show you that yes, on average, patients have higher scores, they've had disease longer, but it's hugely variable. And that variability means that you have to follow patients for longer to kind of sort out what's variability patient to patient and what is actually the effect of your drug. So if you look here in the 5 to 10 year range, there's patients at all different levels of disability with HSP who've had disease for the same amount of time. So to kind of summarize with where we are on our current scales, so they are reproducible. If the results hold up, doctor to doctor giving the scale, you end up with a similar result. They're easy to administer. They are clinically relevant in that they capture things that are important to patients. But they're really not responsive enough on their own to changes in status, and the scores can bounce around when the disease itself might be progressing or might be constant. So the kind of ways to improve this to give us better tools for clinical trials. So one, again, is to develop some disease-specific outcome measures that could be more sensitive to the changes with PLS and HSP compared to our existing scales. And our previous speakers have kind of talked about how that's an ongoing effort and that's going to be important for future trials. And then they've mentioned biomarkers, but I'm going to talk a little bit, give examples from some other diseases about where biomarkers have been really useful. Because I think it's, when you talk to patients about biomarker studies, it's not always intuitively obvious why they're so important and why they actually will make treatments easier to discover. So let me give you an example. So diabetes, which we've all heard of pretty well. So we know that controlling blood sugars is important for preventing diabetic complications. So one of those is heart disease. So if you have high blood sugars, you're more likely to have complications of heart disease. If those blood sugars are better controlled, then you're less likely to have heart attacks in these events. So let's say you have a new drug and it lowers blood sugars and you want to prove it and you want to do this trial to show that your drug works. So you have two options. So you could say, okay, well, my end game here is that I want to show that my drug reduces the rate of heart attacks. So you can take patients, give half drug, give half placebo, and if you want to look at how many patients get heart attacks, you're going to have to follow patients for years to see some patients in the drug group get heart attacks, some in the placebo group get it. You want to compare one to the other. So this might be a 5-year study, a 10-year study to track how many people get heart attacks. But what if you have a biomarker to give you a more intermediate measure of what your drug is doing? So there's a blood test called the hemoglobin A1C, which is a simple blood test, and it shows you what your average blood sugars have been over 90 days. So for anyone who's diabetic, this is something that's monitored routinely in the clinic. So let's say you use this as your outcome measure in the trial. So you could show that your drug lowers blood sugars faster than placebo, probably over a course of months. So by having this biomarker, you can really do a trial much faster by showing your drug did what it's supposed to do without waiting for that final end game to prove that the drug worked. Does that make sense? So that's kind of what biomarkers are. You still care about the clinically relevant outcome, but you have something to measure that allows you to get to that point faster. So I think you're hearing a lot about these non-interventional studies, and I think if I had one take-home point, it's that these studies are actually really important, and even though it doesn't feel like doing one of these studies is is necessarily directly beneficial. It really does allow for progress in the field and gets us closer to developing treatments. So these non-interventional studies that study the natural history and study biomarkers and clinical scales and develop new ways to measure things in PLS and HSP actually are getting us closer to getting effective treatments. So these studies really are progress, even if it doesn't feel like immediate progress. It is getting us closer to getting good treatments. And just another example from why these natural history studies are so important. So there was recently a new drug approved for spinal muscular atrophy, which is a motor neuron disorder as well, and this drug's called nusinersen. And I don't know if you know anything about SMA, but the babies that are affected that have this most severely are devastated by this disease. They never sit up, they have trouble feeding and breathing, and without treatment, many of them pass away before they're 2 years old. So it's a really devastating disease. And there, up until recently, haven't been any treatments to fix this disease. So before there were any treatments, they did really in-depth natural history studies where they knew the expected clinical course for this disease, and they measured how long patients survive and what kind of disability they had, and they had all of this captured before the drug was ready for prime time. And then they developed this drug, and they tracked survival in the drug, but the drug was really promising early on, so they didn't want to give patients placebo. They wanted to give everyone an opportunity in the trial to get the drug. But you have to have something to compare it to. So they were able to take this natural history study, and what you see here, so this is a survival graph. So time in months is on the x-axis, and then on the y-axis, it's the percent of patients who have survived at any given time. So as you go on, you see survival declining. And the blue one is the natural history of this disease, which was established through these non-treatment trials early on. And then the red line are patients who got the drug in this open label study. And so they were able to clearly see that this drug had a meaningful impact on survival, but only because they had this really robust natural history data. So a great example of how doing a quality natural history study accelerated the development of a treatment. To add to this, they also were able to show with their biomarker data that they had the effects that they wanted on the motor neuron. So again, they had a clinical relevant thing, which is survival, which we clearly think is important, and then they're able to show that it had the effect on motor neurons that they want. So the biomarker plus the clinical data together gave that full picture of how this was an effective drug and was able to get approved fairly early in the process because they had these two things together. So really important to have this natural history data when you're then testing treatments. So if you are interested in participating in a natural history or a biomarker study, I know people are here from all over the country, so I didn't want to give specifics, but some good resources. There's this website called clinicaltrials.gov, and all drug trials as well as many non-interventional trials are posted on this website, and it's pretty easy to search. You can put in the disease, you can type in HSP or PLS, and you can search by region to see if there's anything that's enrolling near you. And as drug trials come on the pipeline, those are all posted here as well. And then it's always a good idea to just check it with your neurologist or your local academic institution, and at your visits, they should be able to give you an update of kind of what's happening locally if you are interested in participating in research. So the rare disease issue we sort of talked about, it's hard to actually get exact numbers on how many people have this, but probably about 2,000 people in the US with PLS and about 20,000 with HSP. And while HSP is more common, as trials are developed that target specific genetic mechanisms, there's probably going to be HSP trials for specific gene mutations. So when you're looking just at a subset of HSP patients, then those numbers are going to go down quite a bit. And so having these collaborative efforts is going to become really important in cases like that, where you're only looking at a subset of patients at a time for a specific trial. So this has actually been talked about a lot in the previous talk, so I won't beat it to death, but no one center, even if they have all the resources available, can do successful studies on these rare diseases, it really takes a collaborative effort with multiple sites, with patients from all over the country. And these networks that we're talking about, which right now we're doing mostly non-interventional studies, will then be in place for treatment trials and easily transition into doing the clinical trials for drugs that can slow the disease. So all of this network building is actually very exciting because it's getting us much closer to doing treatment trials in prime time. And some examples of some of these collaborative efforts, and Sabrina talked about this one, the Niels Upper Motor Neuron Disease Registry. There was the first phase, which was just a patient seen within the past 1 year, and the rationale for that was to find active patients with PLS, so we could see if we were to have a clinical trial, who's out there, what do they look like, what should we study. And I won't go over this too much because it's been talked about, but I think another thing that was interesting is we looked at the most common clinical symptoms, and some of them, like walking problems and spasticity, were obvious, but other things like pain and mood problems were more frequent than we expected. So registries like this also let us know that if we're going to do trials to manage symptoms, what are the symptoms that are actually most common in populations? So this PLS study gave us really valuable information about what are typical complications and coinciding symptoms in this population, so we know what's important to our patients. And next year, it sounds like we'll have the data from the longitudinal registry that's being analyzed right now. In HSP, there's also been some robust observational studies. Some of the biggest ones I found, there's a big Canadian observational study with 526 patients and a German study of over 600 patients. And same, these studies provided really robust information about clinical information, complications, rate of progression, disability, genetic information. And these studies really allow for discovery of new genes and for understanding what gene causes what clinical pictures. And these studies really help move things forward to get ready for trials. So to kind of summarize, yes, if we had a cure tomorrow, it would be easy to recognize. But when we make stepwise progress with treatments that either slow progression or improve symptoms, we really have to have ways to measure these things. And with rare diseases, you have added challenges of needing to pool resources to do effective trials. But I think the positive outlook on this is that there are several ongoing and growing observational non-treatment trials that are getting us ready for clinical trials. We're developing better outcome measures, so we're better able to detect change faster. The development of biomarkers, so you can measure that your drug has done what it's supposed to do, and you can maybe see changes faster than with just measuring clinical progression. And it's clear to us that the patients are out there that want to participate, the neurologists and the study sites are out there that want to do this research, and then the network is there and growing to do these trials. And even though it's a rare disease, we are, through pooling our resources, much better able to actually do meaningful trials and get better treatments for this. So I want to thank our amazing patients who are the reason that, that this research is possible, and I think people here particularly are very motivated to see cures and treatments developed, and I think that partnership with the medical community and patients really helps this process move forward. I want to thank my team at Emory, the Spastic Paraplegia Foundation. I know this meeting is really helpful to patients, and the fellowship that gave me training in clinical research and the ability to study PLS was hugely valuable to me, and I know to Sabrina, and is really growing the network of researchers that are committed to this disease. And then the Niels that Sabrina talked about, there's a whole upper motor neuron task force within this group, so researchers that are just committed to developing faster treatments for PLS. And so there's a big group of researchers throughout the country that are motivated to do these studies. And then the last time I was at this meeting in Seattle, I was very, very large and pregnant, and that is the product of that pregnancy in the corner there, just because she's cute, and why not? So thank you very much, and I'm happy to take any questions. Yes? I do think yes, is the short answer, but I don't have the details, but I do think, like I said, I think we're getting a lot closer, especially with HSP, as we have better and better understanding of the genetics, and we're getting much better at therapies specifically targeted to specific genetic mutations. So I think there's a lot of promise there, and I do, no crystal ball. It's always hard to know when things will start, but yeah, I do think that that's a field that's going to be growing in terms of treatment trials soon. Fingers crossed. Yes. Mm-hmm. Mm-hmm. Yeah, so the CREATE registry that was talked about in the first talk is a really great resource. There's an option there to be contacted. Clinicaltrials.gov is not a registry, it's more of a search tool. So it's kind of like the Google for research, but it's more of a database for you to search trials, but there's no mechanism for that to contact you back. So I would say the CREATE place is a great place to start. I think keeping in touch with the SPF, because they are always on the, in the know about what's new and cutting edge, and I think would be happy to help us disseminate trial information as it comes. And then always just, because some of these trials are harder to travel for because they can be far away, I think checking with your local center and seeing what's close by is always a good idea too. But the CREATE registry is a good place to start. Yes? Mm-hmm. Right. And I think it's probably not going to be that there's one single measure. I think it's probably going to rely on combination metrics to get there. So this PLS FRS scale that was mentioned, that the study to start testing that is already starting. So not every site is up and running, but over the next 6 months, there's, I think, 21 sites. So it's going to be done in many different places throughout the country. A lot of these biomarker studies are ongoing, and I would mention for PLS, it's important to, a lot of the biomarker studies for ALS also include PLS patients, and it's kind of a win-win, because if there's overlapping mechanisms with ALS and PLS, then treatments that are developed for ALS could be beneficial for PLS. And if there's differences, then putting the PLS patients in ALS studies could identify those differences. So either way, it's useful. So I would say if you're a PLS patient and want to do some of these studies, also enrolling in ALS studies could be an option. But some of these studies to develop the outcome measures are already ongoing, and I think some will be coming up probably in the next year or two. So, just
to follow up with that.
Yeah.
Do you find that the typical ALS researcher who is focused on that particular disease considers, as they embark on a clinical trial or in this general research, does PLS come into their sphere of understanding?
Yeah, I think it definitely does. I mean, just based on this upper motor neuron task force within the Niels group, a lot of these investigators are very interested in PLS. I think that you can show change in ALS much faster because it progresses faster. So I think that for any kind of treatment that there's a mechanism that applies to PLS and ALS, it sort of makes sense to do ALS first because you can validate it faster and then expand it to PLS. So that is the path forward for a lot of the PLS treatments, but I do absolutely, I think that PLS is not forgotten among kind of the motor neuron disease world. So there is a lot of interest, so that does make me hopeful for, effective treatments down the pipeline. Great, thank you.